So as you've probably seen on the presentation, I'm Fernando Escudera. I'm a faculty at the Center for Research and Teaching Economics in the city of Aguascalientes, Mexico. And I'm a decision scientist by training, and I've done quite a bit of simulation modeling and decision analytic-based policy analysis on the cancer realm, and also infectious disease that cause cancer, and also on some other infectious diseases as well. Nice to meet you.
Hi, I'm Jeremy Goldhaber-Fiebert. Seems like the people on the call keep changing. Now I know everybody on this call, so I'm not going to say anything more about myself.
I can go next. My name is Andrea Lubiano. I'm a research assistant with Fernando Larid at CIDE, and I'm very interested in decision science. I'm a physician, and also I studied an MPH, so happy to meet you.
Valeria, you want to go next?
Yeah, sure. Hi everyone. My name is Valeria. I work with Fernando at CIDE, at Center for Research and Teaching Economics. I have a master in environmental economics, and I have been working on this the simulation of the pandemic here in Mexico.
How's everyone doing? We'll start in a minute.
Oh, hi, Lisa. We just, yes, we can hear you.
No,
can you hear
I
us?
can't hear you.
So, yeah, there might be Lisa's,
okay, I can hear you now. That's my,
yeah, can you hear us?
problem.
Okay, awesome. So we were doing just a round of introduction, Lisa.
Great. And just before we start, is there a Compax tech support person in the room?
Yep.
Yep. I'm getting some messages that some people are having trouble finding the links, and I wasn't able to access them through the browser in Chrome, but I was able to get it on my iPad. So if you could shoot somebody a message and have them take a look at that, that would be great.
Yeah, so I was able to access it on the meeting site.
Yeah, I was using the Edge browser to access. I don't know which.
Okay.
I used I used Safari, and it worked.
Yeah. So I think there's probably a browser specific issue, and then also it was weird because the room was not enabled until very close to time, and I had to refresh my page in order to see the update. So I mean, there may be reasons why breakouts or these other sessions are kind of closed until they open, but I'm basically just like, for the live sessions, I just leave them open all damn day. Like we can go into a normal conference room.
Right.
You know.
Right. Yeah. Understood. Yeah. Okay. So thanks to, I didn't see your name, but thank you to whoever's providing technical support.
It's Nate.
We appreciate that. Hi, Nate. Great. Thank you. So it's great. So I think we will have more people joining as they navigate some of these technical challenges, but it's great to have everyone here, and thanks for joining the keynote this morning. Fernando, this is meant to be an informal session, so I'll hand it over to you to introduce you and any of your other team members that are here, and then we'll just open it up for discussion.
Yeah, thank you, Lisa. Actually, we already started like the round.
Oh, you did? Great. Okay, good.
But yeah, thank you. And also welcome to the breakout session. And so Valeria, introduce yourself. Valeria, did you finish introducing yourself? Because we were having some technical difficulties. So we just want to make sure that you had already introduced yourself.
Yeah, I believe that I did, but if not, I can go again.
Yeah, sure, why not? And we have Seiyu, a good friend and colleague of mine. So welcome, Seiyu, as well.
Hi, Fernando. I was typing, say, oh, I'm going to say hello, and then jump into the other session. But now you catch me, so I cannot stay.
You're gonna leave now, Seiyu. You are trapped in our session. No, I'm just kidding.
Yeah, we still have another session to go to the
sure.
Yeah.
Yeah. So Valeria, you want to introduce yourself also, so Lisa knows you as well?
Yeah, so my name is Valeria Gracia. I work with Fernando Alarid, at CIDE, at Center for Research and Teaching Economics. I have been working on the simulation of the pandemic in Mexico City metropolitan area.
Great. Hi, nice to meet you.
Thank you, Valeria. And Matt, do you want to introduce yourself now, finally?
Sure. My name is Matt. I'm a second-year health policy PhD student at Stanford. Jeremy is my advisor. So I've actually gotten to hear about the SC Cosmo modeling a little bit a couple weeks ago at our Research in Progress seminar. But so I'm the decision science track, and my research recently has been primarily on kidney transplants. So yeah.
I see. Now I see why Jeremy was saying that he knows everyone on the session.
Yep.
Makes sense now. So Say, you want to introduce yourself?
Hi, my name is Taeyu Mishu. I'm a research assistant professor in the University of Nebraska Medical Center. The one we have a huge clinical trial on the COVID-19 drug. And then pardon me, I really have a trouble pronounce drug name, but it's like a Ristamir.
Redissemir?
Yes, yeah. And then it's really exciting to see a preliminary result on based on the current outcome, can we really implement that or not? So I think there's another session, but it's really fun to come back to the SMDM meeting because I have been absent for a couple of years due to the different research priority. And yeah, it's great to see everyone here.
Yeah, great to see you, Say, as well. So just a quick context, put in context. So Say, you and I did the same PhD program in Minnesota, although she was a few cohorts ahead of me.
Yeah, but Flendo now is in a different level now, so.
Yeah, so Lisa, I believe, I don't know if you want to introduce yourself or have already done so. Yeah.
Sure. Say hello. Hi, Lisa Prosser. I'm a professor at the University of Michigan. My research focuses on using methods of decision science to understand the value of childhood health interventions, and currently president of SMDM. I'm really excited to see everyone here. This is really terrific. And I like that it's a really small group. We can have some great discussion. Thanks.
Yeah. So I don't know how to start the discussion. If folks have any questions on the approach that we've taken. I don't know, Matt, if you have any questions about the model, like this system that we've implemented where we get data and have this collaboration and conversations with decision makers. I don't know if you guys have any questions of stuff that we presented earlier or in general about how we deal with this collaboration with decision makers.
I guess I'm curious about the collaboration with the decision makers specifically, because these models really are only useful if decision makers are involved and use them. And so I know you said that things have gone well so far with the government in Mexico, but I'm curious, how did that kind of come about? Did they reach out to you first, or did you reach out to them? And then also, how has it been going recently? Is it just, how open has that line of communication been?
Yeah, no, great question, Matt. So it all started the week of March 16th, when there was like Mexico decided to pretty much shut down, like start the shelter-in-place policy at a national level, and there were no pretty much any modeling teams or any models for Mexico. There was one based on the flu, well, the H1N1 that happened in Mexico in 2009. So there's some researchers created an Excel-based model, I believe at the time, that they used it in 2009. So that's the only model they had. So they started putting some parameters from Wuhan, and they're getting some projections that's kind of like the model they used to make the decision to implement shelter in place in March 23rd. But that week, like different officials were like shopping around for people that would be able to make models or would have models that will help them implement the model for Mexico City, specifically for Mexico City at the beginning. And so I received a call from a colleague saying, you know, there's some colleagues or officials that are interested in doing this model. At the time, I presented a seminar in my institution that was open to the public, that this modeling consortium that Jeremy and I and other colleagues at Stanford started constructing. So when they saw the webinar and I was talking about the model, they said, oh, you know, like we would be interested in talking with you. So they contacted me, and we had like a 3 or 4 hour call at the time, because they wanted to build their own model. They were not, so, I mean, they wanted us to do the modeling, but I was not sure if we would have the bandwidth to do all the type of analysis at the time. So say, okay, we're gonna build our own model. So we have these conversations to build their own model. I gave them different tips and advice on how to build their model. And they built their model for the first like month, and they used that model for the first 3 to 4 months of the epidemic. And they were using it to make projections, try to evaluate what was the hospital capacity adapting to the different phases of the epidemic. And then at some point, there was the model was not flexible and realistic enough to try to incorporate all the different changes that were happening. And that's where they contacted and say, you know, would you be able to provide some assistance? And at the time, we were busy already connected with other decision makers in different states that we had already implemented the model for those states. So we didn't have the bandwidth at the time. So when we saw this opportunity, the SMDM grant to apply for it, so we applied, and those funds allowed us to now increase our team and then be able to implement the model to Mexico City. And we asked them, if we are going to do this, we should be able to have access to certain type of data that might not be public, but it's needed for the model for us to adapt it to the best, to our knowledge, to the current situation. And they've been very helpful. And we even have a WhatsApp group that whenever we say we have questions about the data, whether they could get access to more data and provide it to us, and they're like very respondent. But it's a key characteristic of current decision makers, because it's quite a relatively young group. And that group is like a sciencey based group. So there are a bunch of applied mathematicians and economists and statisticians that, like, I would say the average mean age, like the mean age of that group might be around like 34 years old, 35. So a lot of them coming out of undergrad or master degrees, very like interested in applying data science-based method, decision analytics, simulation models. So they're very open, and we have very rich discussions on, they want to learn more, different techniques. For example, when we present how we calibrate it, we're extremely interested in learning the techniques and try to implement those in other models they're trying to build. So there's been, in this particular case, a very great experience, but it hasn't been the same. There are other states in Mexico that have reached to us, and the approach is quite bureaucratic. And they challenge us in every single way. The model, why did your model doesn't do this? Why did they do that? But why should I believe your model? So they want us to help them, but at the same time, they just want to, I don't know, just criticize everything about the model and what the model cannot do, instead of saying, this is what it can do, and this is how we can help you. But instead, but the case of Mexico City has been a great experience, same as the state of Hidalgo, that we have also close collaborations with them. So that's kind of wrapping up what's been happening so far. Hi, Bob and Victor, welcome to the session.
Hello.
And also, I believe,
how are you?
Victor, welcome.
Hello, everybody.
And Betty, hello, welcome to the session. I don't know if you guys have any questions. So we were just discussing about, yes, you.
I think my question is more on is there any like a government official was healthcare professional really adopt this, take into account the result of this decision modeling, the outcome results, and then the other question is, yes, what do you have? What is the dissemination plan to in the Mexico to be more widely used, where people can really refer to this and then based on their like a local policy?
Sure. So in terms of the dissemination internally to decision makers, we held meetings with them. So we presented the preliminary results, like the ones that we produced 2 weeks ago, directly to them. So we had a session in which we showed them the results and how we are projecting for the epidemic to evolve over the next few months. And then we had a conversation on what other strategies they would like to see or evaluate, what would potential outcomes they would obtain if they would implement, especially like strengthening quarantining. So go on and about do more testing, and once they detect more cases, try to incentivize for them to don't go out and isolate themselves, and try to whether it's worth investing some efforts on doing that. So we took notes on what they would be interested, and then it would be go and then how we can implement those strategies in the model. And that's what currently we're doing, that to update the new round of different policies they want to see. In terms of the widely dissemination, in fact, as I was presenting this morning, some social network collaborators started disseminating our results in a policy, roughly like a policy brief, and contacting local and national news media, so they know what our predictions are.
So one follow-up question is, there's some pushback, different trust issue. Do you encounter any kind of in Mexico as compared to the States? Well, surprisingly, not as much. So I have other colleagues, for example, the team of Eva Enz and Lauren Cipriano. I know when they did all their modeling efforts in Minnesota, they encountered quite a tough pushback and kind of like a load of not so positive messages. So it was even a senator or a congressman in Minnesota called out one of the programmers by her name and where she lived, and it was a Republican senator. So that was quite a bad experience for her, because she was completely trolled, and it was a terrible experience. So I thought something similar would happen for us in Mexico, but it was not as bad. I mean, actually not bad at all. We didn't receive any negative comments, or sometimes like, oh, why should we trust your model, or those type of questions, but not as harsh as what I've seen happening in the States. That's quite new. Thank you. Yeah, and also in Mexico, there have been some modeling efforts, but they were happening at the beginning, and then they didn't move forward recently. There's been some other projections by IHME and a couple other groups, but again, they do and I mentioned this earlier, that they do the projections of the pandemic at a national level. And we've seen that their projections haven't been that accurate, because the country is moving at different paces with different NPIs implemented at different times. So it's tough to come up with an overall projection just by modeling the whole the country as a whole.
I have a question. So not that it isn't challenging enough already to be modeling the Mexico City area, but do you have plans to generalize or adapt rather your model to other regional areas, either within Mexico or elsewhere?
Yeah, so in fact, for example, Valeria is on the works of doing the implementation of our model to all the states in Mexico. And we actually have already done so. But the challenge here is, even though the model is a compartmental model, is a deterministic, is somewhat computationally intensive. Just to put in context, one single run with a parameter set might take 6 seconds. But if we are going to do uncertainty quantification and propagation by using the Bayesian approach for the uncertainty quantification, we may have to run the model like 300,000 times to explore the parameter space. And that adds up. So we've implemented this parallelized approach to do the Bayesian calibration, but it's doable in our current computer settings for maybe a handful of states. But once we do, there are 32 states in Mexico. We're currently working also with Jeremy to use different computing systems and we have now granted access to a couple of supercomputers in Mexico to be able to calibrate all states and then be able to do these projections at a state and national level by aggregating all the state projections. So this is what's currently.
So just to add to that, so Fernando and I basically use the same sort of underlying modeling framework and code base. And we're calibrating essentially the 58 counties in Mexico, or sorry, in California. And we're using AWS and, you know, using about 4,000 cores. It takes a couple of hours to kind of calibrate all of those counties. And then we have a sort of a bootstrapping approach to kind of go up to simulate the state level in California from those county level simulations and quantify the uncertainty that way. But, you know, like, so I actually started a calibration yesterday, and I'm just about sort of finished with projections that will push back out to the state later today. So, you know, we're using kind of cloud computing resources, and we have some servers that Fernando's group and my group share, including some stuff that's been donated by AMD and things like that.
Mm-hmm. Right.
Yeah, and that's why having like being a grantee of the More Foundation CDMI grant initiative has been really helpful, because basically we were limited by the amount of resources we had. So this has been able to allow us to use some of those resources in a way that we now are able to do, for example, this Bayesian calibration and probabilistic projections of the model for Mexico City. Yeah, and
I'm curious. So, so you've adapted the same model structure to 2 different geographic areas, but have you had to do additional tailoring or adaptation in response to what type of information decision makers are looking for? Has it been different in the different locations?
I would say that, you know, a lot of people want the basic stuff, right? Case rates and R effective and hospitalization and whatnot. And so a bunch of the tailoring is about parameter tailoring, fraction of people who are hospitalized conditional upon being symptomatic and those sorts of things. So a lot of the model is parameter kind of specific. Once you get into intervention scenarios, then I think it starts to diverge. And the other one is how people want to think about sort of subgroups, right? So there's, of course, a lot of talk in the States about race ethnic subgroups and disparities, inequities, and outcomes. But like in Mexico, I think it's probably the case. I mean, Fernando and team can say a lot better, kind of what are the key ways of kind of stratifying or.
Yeah, and it's also, even the structure is the same. We also have, for example, estimate when we think the different social contexts, the behavior changes. And for that, we use Google mobility data to estimate what will be the potential changes on mobility. And that obviously, these changes in mobility are different across different settings. So once we do this estimation, it determines also the number of parameters, because then we estimate piecewise sections of time frames at which we believe there's some rough similar social contexts, and that varies by a setting, and depending on the number of pieces, they also determine the number of parameters of the model. But the way it worked, we developed this basically R package, which is the modeling framework, and then each of the settings loads the R package and then builds in custom functions to suit the different needs of the settings. For example, interventions, we have setting-specific intervention functions that will just read in the model and take the outputs or implement the interventions into the model.
So like, I think going back quite a number of months, but just as an example, I remember at one point, one of the early states that Fernando and team were working with, the set of people that they were expecting or wanting to sort of stay home and sort of shelter in place was quite different from the subset of folks that California was focused on. And likewise, California was interested at some point in the sort of these like pulsing strategies and sort of back when sort of building up herd immunity was sort of the in vogue. And at that time, I think there were very like in our discussions, the sort of Mexican state that Fernando's team was working with were interested in other things. I think primarily around healthcare equipment and healthcare capacity kind of concerns. right? So we were getting different questions, but we tried to engineer things in a way where it's less about custom implementation and it's a lot more about custom parameters and whatnot.
Interesting, really interesting. Thanks.
Yeah. So, Lisa, at what time should we break out?
Good question. So we, it should be right about now. So if there are any other questions, you can go ahead and maybe time for one quick question, but then we're supposed to start up at 1:10. So you can take a quick break, 5 minutes, or
yes, you.
Actually, I have a last question. I think Jeremy mentioned a real point in the, because what I think the difference between the Mexico, California, or California versus the other state of the United States is I think that there's a huge difference, like a racial ethnicity group composition, and then each have different culture have a different health behavior. Even you have a shelter in place policy, but in some culture that's not their nature. So is there any way we can really take this into account, the health behavior based on different race ethnicity? I'm just curious. Yeah, you are such a diverse state or population there, so it might be a really good place to conduct this kind of research.
So
I can let Jeremy answer this one.
Yeah, so we've been also kind of on data analysis side, kind of worrying about or thinking about these sorts of questions. In the context of compartmental models, essentially you need to stratify in order to have heterogeneity. And there's a limit at some point to doing that, in the sense that if we're currently simulating a system of a couple of hundred differential equations, and we also need to stratify by we're by age and disease status and detection status and a variety of other things. So if we also add race ethnicity, I think that will that sort of greatly does it. So that's sort of the kind of variation or heterogeneity across. The other way to do it is kind of having time varying sorts of things. If you're still just interested in the overall mean, as the composition sort of changes, you might have some sort of time varying, even though within one group it might be different. As the composition of the group who's infectious changes, then that can lead to a time varying mean. So, but it depends kind of on the question you want to ask, and also whether you want to report separately on outcomes, right, within those groups. The other way to do it, of course, is to sort of make models that are of smaller and smaller geography, right? And then kind of combine them up. So, you know, the much more heavily Hispanic Latino area of Santa Clara County and the area that is Asian Pacific Islander, that's more, you have separate models and then have them, you know, interact in some sort of way. But again, it's just sort of computational burden. It's another way of stratifying. I don't know, Fernando?
You know, I think it also, like, based, like you're doing also like county level models, it also tries to capture the mean behavior of the people living in the county, and perhaps those counties have certain type of race and ethnicity concentrations. So that's like one way to capture it. Yeah,
I think in other settings, it's like it might be a socioeconomic kind of thing, right? Like people who are poor and are kind of essential workers, you don't go out of your house, you don't eat because you don't work, right? And so you get behaviors like that, and that may be relevant in some settings, urban Indian settings. It might be, I don't know, maybe parts of Mexico that might also explain a lot, even if it might be more sort of quote unquote culturally homogenous or something like that.
Mm-hmm.
Thank you for your response. I think it is anyway, this is fantastic work you are doing here. Yeah.
Thank you, Sayu, for joining our breakout session.
Say hi to Caleb for us.
Yeah, yes, sure. I think he's somewhere else in the session as well. So
yeah.
I'm gonna head it too. Thanks so much, everyone.
Yeah, thank you. So it looks like we should move on to the next activity, right, Lisa?
I'm chairing the session. So I'm introducing the modeling team. It's Lauren Cipriano. She was here, but she got a phone call. She's probably coming back in a few minutes. And then Eva Ens.
Hi.
Hi. Yes. And then I just, what?
Do you know the rest of the team? I can also introduce who else is here.
Okay, perhaps you could do that.
Yeah, right.
Because that's all the names on my list.
Yeah, so Erica is here. She's also in London, Ontario at the University of Western University. What's your branded name now? I don't know if you want to say a sentence about yourself, Erica.
Yeah. Hi, everyone. I'm Erica. I'm doing a dual degree with epidemiology and biostats and business, and I'm helping out with building contact matrices and kind of testing out some of the assumptions for the model and doing a lot of the kind of base research about what kind of occupational groups we're going to choose or we're going to put into the model. And I'm very happy to be a part of the team.
And then we also have Farzana, who's on. Hi, Farzana.
Hi.
Say a sentence about yourself.
Yeah, so hello, everybody. My name is Farzana, and I'm a postdoc at Western University, Ivy Business School. And I'm helping in this project with Eva, Lauren, and other team members in like conceptual modeling and then trying to code the entire model. I wasn't like working in this field. My background is industrial and systems engineering, and I'm new to health systems actually, but I'm very happy to help, and I really enjoyed today's meetings, all meetings and panels.
And I see Lauren's here too, but I don't know if you have any other things you're supposed to say to Torbjorn as the host.
Yeah, I don't think I have anything else to say. No, I just we can start the questions if any of the others have questions. If not, I can start. I had a few questions on my list as well. I think one of the questions that was raised earlier, I think it was Kathy that raised it, regarding the data. So I think it's very important, or these times show how important it is with modeling. But one thing that's not stressed enough, I think, is the importance of having good input data. And then, of course, the importance of this good descriptive epidemiology. And I think it's a bit sad that journals and funders and so on, they typically don't like descriptive epidemiology, but we are very dependent on it in the modeling community. Can you say anything about your, did you get any good data, and do you yourself feel that it was kind of good enough?
I think here locally, I think we're dealing with the same sort of lousy data that everywhere has. I don't think Eva speak to the Minnesota data, but I think it's also this quality. And in fact, one of the things that I tried to work with the decision makers here locally on was understanding the importance of getting some statistically unbiased trajectory and surveillance information. And we talked about that as not even, it would be useful for the modeling. I think that would certainly help us calibrate the models and validate the models and do more tailored work. I think without good surveillance data, we can do this policy comparison idea and understand policies that are going to give bigger impact versus smaller impact. But I think for actual local decision making right now in Ontario, we have just reduced our testing strategy from anybody can get a test, anybody who feels like they have a contact can get a test, to a situation where we are only testing a very restricted number of symptomatic individuals. The test backlog is now 90,000 tests. The test response day is 5 days to get your test result. we have now resulted in a testing system that is clinically useless and epidemiologically useless, and for local decision-making, absolutely useless, because they're now discouraging so many people from getting tests. We are back to the paradigm of April, where if you had an exposure and you have symptoms, then don't go for a test, just isolate and assume you have it. And using that type of information to make your decisions as individuals, now we don't have that information to know when we can see something happening that's going to be bad for the hospital 3 or 4 weeks out. And our hospital teammates are saying to us, we need 3 weeks notice. 3 weeks allows us to decant patients in a way that is safe and maintains prioritization for the most acute care. And we can't do that because we're literally turning data away. So I think on the modeling side, good data is a privilege, but we can work without good data. On the actual decision-making side, we become paralyzed because you don't even know where you are in the model's trajectory. Eva,
Yeah.
how's it your data?
Well, I think adding to that, I mean, I think even when you have access to through your local partners, and I see one of our local partners has just arrived, so I'll introduce him shortly, but you know, when you have access to the data holders, right, you can get lots and lots of data from them, all the data they have, but you're still stuck with the data that is being collected. So it depends on who's getting tested. That is going to determine who's in your case data set, even if you're looking at individual level data. And the surveillance, the way that the data is reported, the fact that, especially in the US, you have fragmented healthcare systems. So the healthcare systems then have to come to some coordinated agreement about how they're going to report data and code data. When you're looking at hospitalization information, you have scandals about different systems for collecting hospitalizations that are trying to be more real time and providing hospitals with capacity information. Where do you even send a sick patient right now, given what you know about this, again, fragmented system of hospitals and who has capacity for another patient. And so all of these things become really hard. But I think to Lauren's point, again, the modeling when you're trying to provide insights, and I think this is where modeling can be really useful, and there's kind of a desire for it to just tell you what to do, or tell you, when we're talking about the super spreader events, tell you where the super spreader event's going to happen next. And modeling can't do that. It can't. Certainly not the modeling we do. And you know, the forecasting models, they're just fitting the curve, which is why they only go out a little bit, because you don't want to pretend that the trend is going to continue because you don't know what the future is going to be. So I think that's one of the challenges in all of this is, yeah, that distinction, I think, between decision making versus modeling. And it relates to that question on how geographically specific can you get that we had in the chat. I don't know that we spoke to it, but the kind of zip code level modeling, sure, you could call it zip code, you know, 55455, that's the zip code for the University of Minnesota, but like, you're just pretending that it's a population that looks like, you know, an average population in Minneapolis or Minnesota even, and shrinking it down. You're just scaling it down. You don't know enough. You don't know how those people come into contact with each other. And by the way, people from one zip code interact with people in another zip code in many parts of the country. So what do you do with that, right? So I think having these more representative models tries to get away from that level of specificity that then can create a sense of more kind of predicting the future that is easy to kind of want models to do, but they ultimately can't. And so just before we talk about next questions, I just wanted to introduce Stefan Gildemeister, who's from the Minnesota Department of Health, and he has been working with us since March. Hi, Stefan. We know each other really well. And he was one of the, I gave birth to a baby in June, and he was one of the first people to know that I was in labor, along with Lauren, because we were working on all of these things. So Stefan, I don't know if you want to say a sentence about yourself and kind of the health department's perspective. I think a lot of the people here are modelers, and so your perspective is really helpful. And you are muted in case you don't know that.
Yeah, before March, I was happily looking at the healthcare market in Minnesota, the economics, the efficiencies, how we can encourage access to healthcare coverage and healthcare services. I lead a team of 20 analysts, and we just do a ton of work that is completely unrelated to infectious disease surveillance or modeling. But the way I got into this game and working with Eva, which of course has been both pleasant because I get to work with Eva and to some extent Lauren, but incredibly unpleasant because of the politics surrounding the virus and the response, was that, you know, the governor said, where's our model? What do we know about modeling the epidemic? What's the impact going to be? I need to know. And we looked around the agency and there was really no one with the expertise or the knowledge or the bandwidth. And so we looked at building something from the ground and stumbled across each other and ended up working together, which was fortunate and fun and interesting and scary. Yeah, but there's a lot more to say about data, of course, and Eva was exactly right. You know, you work with the data that you have, and hopefully over time it gets better. But also about sort of the difficulty of science communication, or you know, being the bearer of unpleasant news, of being clear enough about what your model can do and can't do, and sort of fighting the counterfactual out there when other modelers present data that imply what their model can do. So it's been quite the rocky journey, but we've benefited so much from not just the work of all of you, but also of you know, the CDC teams that bring modelers together, Midas calls, you know, published work. It's been really valuable.
That reminds me too, and this gets to some of the themes I think from the keynote this morning, of just that not all modelers have the same opinions about modeling and its capabilities. And there was a lot of promising on the part that was sometimes problematic if you were trying to walk back and say, no, lots of uncertainty, we're comparing things, we're not trying to project anything. And then you had, in the US, we had this, I think, because they had these state models, the IHME model from the University of Washington, which, you know, if you remember in the beginning, it had these really low curves that they were predicting because they had some very strong assumptions about people's behaviors, and that we would have a Wuhan-like lockdown for like 9 months. And that would keep the virus suppressed. So we were kind of having, they were saying, well, why do you predict like tens of thousands of deaths and this model predicts 100? And you'd have to like then get into these differences and try and justify like someone else's decision, you know, or lack of decision on something, and compare it to yours without entirely even knowing what they were doing because things were changing so quickly. Yeah.
Right. So you know, Eva's model is a mechanistic compartment model, but then we sort of had to look to understand what IHME does in its curve fitting, and how their model and the methodology sort of changed weekly, monthly, tracking how estimates changed. So that wasn't helpful. And I think, you know, with the next epidemic, maybe we have a more federal approach to some of this with some guidance and some structures and some best practices. But for the current one, we don't have it. And that means probably we will struggle through these same pain points, you know, until next year about this time.
So I want to be mindful, we've talked a lot, but are there any questions from the...
I have a really quick question I have to pop off at one, but so I probably won't. It probably requires more time than I have, but one of the things that we've seen, particularly in Ontario, is a question about alternative options to dealing with data collection that are not actually about data collection, but rather about, you know, political gamesmanship of the testing backlog and trying to solve other problems in the healthcare system. I'm thinking in particular of the question about, well, should we allow private labs to run testing or not? And I'm curious if you guys have any thoughts towards particular policy efforts that have been more successful or less successful in both improving the quality of your data, but also in terms of improving the overall quality of collection of data.
So I definitely agree that and I don't think that it's restricted here, but we have certainly seen it here in Ontario, that people are seeing this as an opportunity to try to do other things. That they know the types of solutions they would like to be in the healthcare system in a non-COVID world, in a post-COVID world. They are also what they liked 5 years ago, and they're trying to figure out how, in this moment of crisis, to enact that type of change in the system. And I think that's not just restricted to us. So we're seeing pushes towards trying to adopt more privatized solutions. Certainly in the US discussion, you're seeing, is this going to be the point where this changes what public healthcare looks like in the United States? I imagine Torborn could tell us that in Norway, there's political discourse around how should this be reshaping our entire healthcare system, and it's not so much that people are developing new evidence-based views, but trying to contort the facts of COVID into their prior ideologic views. That is, I think, the nature of too much politics everywhere. I think that one thing that is disappointing to me is the lack of discussion around evidence, and the lack of discussion that we've had around prioritized values. And the only time I've actually seen our public health officials explicitly say we need to prioritize our values was actually yesterday in our local small medium-sized city newspaper, because they on no notice decided to close all of the strip clubs, and they gave nobody any notice that they would suddenly be unemployed, and they said this is the government making a value-based decision about what kinds of businesses are going to be the priority in our community. And but other than that, we have not seen an emphasis around schools over bars. We opened the bars 6 weeks before we opened the schools, the elementary schools. So we are not having a very effective discussion around values, as though this is a knapsack optimization problem where you can put some things into your knapsack, but not everything's going to fit. And you might want to have that kind of a conversation about how do you make your knapsack bigger through engineered solutions in workplaces or screening strategies that might actually give you more space. And then what types of things are you going to put in first to rebuild your society? We're not having that kind of a conversation. We're not having the kind of conversation that might give us the data to help inform those decisions, but we're not even having an abstract concept discussion around what are the things we want to prioritize, except when they want to throw the most marginalized in our society under the bus again. And I think that those types of things are just cheap instead of substantive.
Any other questions?
That was a great answer.
On that
Thank you.
note, I think we have 5 minutes before people switch out and we get a new crop of.
I have a quick question. Can you hear me?
Mm-hmm.
I was wondering if you could speak to engaging with policymakers on your work, and I'm thinking in particular with regard to the trade-offs of sort of making your model perfect and complex versus speed and simplicity. And I think we're sort of all used to like spending years on an analysis and perfecting it to publish, but these decisions need to be made yesterday, and you know, policymakers want to see like model results now. So I was wondering if you could speak to that.
Yep.
Eva, do you want to take it? I can.
We had that experience in March. Yeah, the speed with which, and just, I mean, just even how decisions and like briefings and information is conveyed was a whole learning curve for us as well about, you know, when when are results needed? What's the kind of chain of command in terms of who gets what information when does it go to the governor? We were in some meetings with the governor, which was fun and exciting. He said our name. So it was interesting, but it was definitely learning how to get results quickly. And I think, and so we tried to put those caveats in as much, and we also just didn't know very much, right? There was no perfect model because our knowledge was incomplete, or we were relying on mortality estimates that we know are wrong. We just don't know how wrong they are. So I think like doing more robust sensitivity analysis would have been nice, and having more quantification of uncertainty in those initial estimates would have been nice. But I think what was appreciated by policymakers ultimately was really, and I feel fortunate that our governor kind of had this attitude towards what we were presenting to him, was really, again, that intuition about like, how do things move the dynamics of the epidemic, broadly speaking. And sometimes there would be, in the discussion in the media and with politicians, there'd be a little bit of like, oh, but like, is it going to be this week or that week? Is it June 1st or is it, June 15th? Like, but for the most part, I think there was an appreciation that this is really about gaining insight into essentially infectious disease dynamics, and less about trying to predict what will come next. There was much more prediction discussion happening actually in the hospital system. And so we think, like, I'm biased, I think, towards like the health department and surveillance data, but there's a whole like other constituency here, which is the healthcare system.
Yeah, I've worked a lot with the local hospital system, and so I used a much simpler model. So even I were talking at the beginning about the models we were building, and I built a much simpler model than the model that she built initially for Minnesota. And now we're collaborating on a model that makes both of our first models look like Tinker Toys. And is much more elaborate and detailed, because it takes time to build a model like that, and even to know what level of detail we think is going to make a difference. When we saw we have completely restructured the economies in everywhere, and completely restructured the way that people are going to contact in places like here, where we were in fairly significant shutdown for a fairly long period of time. I don't know that we go back ever to exactly what our contact structures looked like before. And so trying to think about how could we even put that kind of uncertainty, can we really use a 2008 contact survey to inform how people are going to be interacting, or do we need to completely think about how that's going to look, and be more circumspect about the uncertainty that doesn't come from the data, but comes from our knowledge of how the world has changed, I think is important. I also think one of the things that has been a privilege is having these very close relationships with some of the stakeholders, where you're not just presenting to them, but having these iterative conversations with them. The first time I presented work to Whale, he said how long it's high. And he's like, and I was like, what do you mean? And he's like, that seems like a long time. And I was like, oh yes. I'm like, it looks like if we don't have social distancing, at least at this level, that we're talking about something that could be 2 or 3 months, because once you reach a certain stage, you're going to see reaction. So it's going to push down, but how long it takes for any of that push down to actually cascade into outcomes in a hospital, you're talking about also leading people differently on your team. And so we've also talked about those types of frontline. If you are the chief of critical care, if you are the VP of operations in the hospital, how do you also plan for your staff working under such difficult conditions for a long period of time? That is different than asking your critical care staff to respond to a natural disaster like a tornado, where you might have an intensive period of high stress, but it's short-lived. We're now asking people to deal with a tornado every week for the next 3 or 4 months, potentially, if what we see is slow response. And I think that's certainly what we've seen in some US communities, is their burden is just going to be an endurance run as well. And so it's really about where are you shifting that endurance request. you ask for people to stay at home and socially distance at an intensive level, you're asking for a population level endurance. If you push it into your healthcare system instead, because you've got very low levels of social distancing, then you're asking for a lot of endurance out of your healthcare workers. And we haven't seen a lot of public reports about it, but a lot of private reports about high rates of retirement in the healthcare sector and high rates of retirement in long-term care facilities. And I think that as we see that stuff rolling out, our healthcare system is going to look different, and I don't think the way our politicians are expecting in 6 months.
I think the time is up, but I don't know how this works. Do we now shift to another room?
I think we stay, and I think people can leave.
Yeah. People can leave and go to a different room. Yeah. And we are staying to see if someone else is coming in.
Yeah, I mean, this is new for everyone, right? No one knows how to run a conference online.
Thanks for your time. I appreciate it. Learning a little bit, getting back in, especially since I haven't been in person for a while.
Glad to have you back, Caleb.
Thanks, Lauren. Bye.
Thank you. Take care.
Bye, Tess. Good luck in your model.
Thanks.
Okay, now it's just us.
For about
and I see
10
Pam
seconds,
is here. Lauren, I don't know if you've met Pam, but Pam's also at the health department.
Hello.
Hi, Pam. Nice to meet you. Torbjorn, I was thinking about your question, and one of the things that I think will be a SMDM analysis in a few years, we'll see the presentation, is looking at the demographic characteristics of the people who got tested in these crisis times. Because I think that if we were to look over the last 60, 90 days in Ontario, I think we will have seen a high socioeconomic status amongst the people selecting into testing disproportionately. And the longer the wait times get, everything we already know about economic decision-making in healthcare says we are going to see even less testing in lower socioeconomic groups, and people who are marginally employed, and people who are paid hourly wages. Nobody has the time to wait 6 hours in a line to get tested when they've got a symptom as vague as a runny nose. And the people in our society that are the most motivated to do that are the parents of very young children with a just runny nose who need that negative test result to put them back in school.
Right.
And so
the parents have access to school or childcare.
Yeah, the parents with access, yeah. So so now they've changed the rules that one sign like that and you can keep sending your kid to school. Your now kid needs to have 2 symptoms. But again, a runny nose and a fever is also not a particularly rare thing in a 6 or 7-year-old. And so those people are getting up very early so that they can maintain access to school, so they maintain access to childcare. But I think it will be very clear that many of our individuals at highest risk who have frontline jobs, who work in services, who work in manufacturing that might not have great plexiglass solutions between every single person, those people are not waiting 8 hours to get a test only to learn that they need to take 2.5 weeks off work for mild symptoms. The economics are just like obviously set up to fail there. And I think that's a problem.
And the other thing is, you know, maybe in Canada, you guys are a little bit more level-headed than we in the US, but it's a really tough message to communicate to those essential workers that they have to stay home with their kids when, you know, the president waltzes in and out as an infectious person, as a known infectious person. So balance that against other people who have less disposable income, fewer options, you know.
They don't have a personal helicopter taking them to
for
get
example.
tested, for example.
So it's an incredible.
As an example, so our Prime Minister's wife tested positive, I think, early on, and they did follow all of the guidelines, which was nice role modeling, very, very early on. But yes, I think many many leaders, but even many leaders in our medical community, I've been surprised at the messaging from some clinicians around, well, most of the tests are false positives. And even I have tinkered with that. Like, this message around false positive results out of nasopharyngeal tests is so frustrating to us who focus on the evaluation of diagnostics in a normal world. And it surprises me, but even then, our billings in Ontario for physicians who are often paid fee for service, so we have a public system but a fee for service system for most physicians, their billings are down 70%. And their own economics are a problem.
So how did you get in touch with you had a Montreal link, right? Montreal
Yeah.
or something.
That's right. Nadia, who is hopefully joining in a minute, is from Polytechnique Montreal. I guess there was someone, a friend of mine when I was doing my PhD, a student came to MIT visiting from Montreal, and we met, and since then I've met her friends, and Nadia is one of the people I met through her. So
okay.
Yeah.
Right.
Do you have a connection with them?
Well, yeah, I'm a SNDM member, and I've been around for a while. I come from operations research. So actually, so it's sort of related to what you're doing, I guess, isn't it? Yeah, it's DES. So yeah, I've been doing medical for a while.
Yeah, I'm new to this area. I am so sorry for the disruption.
Okay.
I'm new to this community, actually. I've done modeling work, but not in the medical sphere too much until
Sure.
lately.
Yeah. Right. Discrete event, you can do a lot of stuff, right?
Yeah. I do a range of simulation modeling. So my expertise is less in the method specifically, but more in how do we look at a real situation and figure out how to model it. It's sort of the connection from practice. So I have sort of some qualitative research expertise that helps me to be able to make that connection.
Okay.
I use
that could be quite challenging, I imagine.
Yeah, it can be. It's fun. It's what I really enjoy, because you get to work with the people who are doing the implementation of the work, which I love. A lot of my work is in disaster response. That's more where my background comes from. So.
Okay. Wow. Yeah, the modeling challenges must be significant. It's particularly the data that you have to collect or not be able to collect. Must be a real challenge. Disaster simulation could be really open-ended as far as data, I'm sure.
Yeah, it's interesting. There's either too little data or far too much data, but not useful data.
Right. Exactly. Yep.
So,
not the data you want.
Right. And it's been interesting in the medical side that there's just so much more data collected, because especially in the US, right? Hospitals collect data. It may not be in the format you want it to be, but it does exist. Whereas,
Right. Yeah.
global health, they just don't have data. It's like pieces of paper in a briefcase. So, yeah. Where does your work normally? What is your work?
Well, I've been doing information value. I'm emeritus now at Northwestern, so I'm not necessarily focused on medical, but I do occasional cost effectiveness projects with local physicians here, where we did lung cancer screening using MRI, a cost effectiveness paper on that. And I've got my own cost effectiveness software also that models for Markov models.
Interesting.
Usually the Markov model is a model of patient progression. So I've been perfecting that in my retirement, because you don't get rewarded for that in academia full time. So
familiar with those challenges, yes. Yeah, there's someone at Northwestern that is in my little disaster response community, Karen Smilowitz. Did you know her?
Of course, yeah, that's right. Yeah, Karen, she's very good. Yeah,
she's great.
I wonder if I don't know if she's since I don't talk to her since I'm now retired, but I wonder if she has interest in COVID modeling at all. Seems like she's a real applications person, so she might get drawn into that.
Yeah, I haven't chatted with her either, but Informs is coming up, so I suppose if it's anything like the non-virtual version of itself, we will see each other. But that's great. Yeah. Sorry, go ahead.
Maybe are you presenting this at Informs?
Maybe there was some sort of mix-up. I put my student, front and center for Informs, and it's not clear to me that the abstract actually got scheduled.
Oh, okay.
But we were supposed to. So, this is really a new effort, right? We've only been funded for about a month, and so there's not a lot that's come out of this one. We're building on previous work in a different area.
Right, right. Do you know Barry Nelson?
No, I don't think so.
He's another simulation person in this department.
I don't think so. I have a crying baby. I'll be right back.
Okay.
Sorry. There we go. I'm back. For better or for worse. You're gonna be good. This may be all we get to do. We shall see. We shall see. Yeah, it's okay. It's okay.
Oh, we had someone appear and disappear.
I saw that. I must have gotten scared away by the baby crying.
Yeah, maybe.
We shall see. We shall see. Yeah, I've just gotten, not coming from the medical side, cost effectiveness modeling is not as much of a thing in the disaster response community. Yeah. So I've just been starting to learn what it is and what it means, because we'd like to be able to use our models to do something like that. And we're trying to figure out, there's obviously like a whole method and an approach that it sounds like you're, a big part of, and this would be a little different. Have you ever seen cost effectiveness models using something like a discrete event simulation model, or is that too detailed for the kinds of costs that are being?
No, it could be applied as long as you have cost outputs and effectiveness outputs in some. Usually it's life years or quality adjusted life years in the medical area as the measure of effectiveness. In which case you have this automatic trade-off of $100,000 or $50,000 to $100,000 per quality adjusted life year. In that case, but if you have other measures of effectiveness, you can also use cost. It's basically we're trading off cost and benefits.
I mean, we obviously think about those kinds of trade-offs, but not in the same structured way as this literature seems to. So that's been an interesting thing for me to learn about.
Right. Yeah. The model doesn't matter so much. So yeah, because you're doing. What are you doing? You're doing. The kind of thing you're doing is for testing. Right. So you might be modeling, comparing different modifications of the testing procedures, right? And you could say, okay, what does that cost? And what are the benefits in some ways, So you could easily do a cost effectiveness in that category.
We've looked at, and there's different types of costs, right? There are sort of the upfront. So when we talk about this kind of testing, but there are upfront investments in, let's say, instruments, but then there are sort of ongoing costs of tech, lab techs, and those are different kinds of costs that could be.
True, they usually do discounted expected costs is what they usually do. There's nothing in principle to say you couldn't do certain equivalents. If you had a utility function of some kind, there's nothing to say you couldn't do that, but usually it's just expected costs. And it's discounted, time discounted expected costs. So those who are, I guess Harold, I see Harold there.
Right. To be honest, I'm supposed to be moderating something, and I never got. I'm not supposed, but you guys seem to be a small group, so I thought I would join you and
Okay.
hear what's going on.
Yeah. So there's no presentation in Erica's session. She didn't plan a presentation, just a discussion.
Yeah. No. That's
yeah,
perfectly
so that's
fine.
all we're going to do. So feel free to chime in.
Yeah. No, that's exactly it. And so keep on going, and I'll chime in.
Right.
I'll just actually. Do decision makers find any of these cost solutions convincing?
From which kinds of models?
Right,
We're sort of talking in big generalities.
Right. So we've been talking certainty equivalence for a few decades, and we've been talking about discounted costs for decades. I'm just curious from your experience, both your experiences, do they resonate with the decision makers?
I think that's a question for Gordon for the first part. My experience is really different and might be useful, but I'd rather hear what Gordon has to say first.
My decision makers are not so present. It's sort of, I do cost effectiveness stuff in medical, and so basically the goal is to publish a cost effectiveness analysis, and you hope that people will look at it, but you don't actually have the person who's reading the paper sitting there in front of you saying this is worthwhile or this isn't. So I guess I'm not really the proper person to answer either. But for simulation models, I would think that the graphical interface kind of models would be very convincing for a decision maker. I don't know if you're planning to use that with your project.
Yes. So I was saying earlier that this COVID testing project is only really a month in, so we haven't really developed specific results to see for that. But this is all building on work that we did with the same kind of modeling in a cervical cancer screening application in Peru, in the rainforest region of Peru. And there the issues are obviously a little bit different, but the key was the sort of ongoing interaction with the decision makers that helped them to sort of buy into the kinds of results that we're seeing. But what we haven't specifically, we specifically have not yet done in that work a cost effectiveness analysis. So what the decision makers that we're working with are concerned about is, let's say they've already done the sort of policy level decision, and the cost effectiveness analyses were instrumental in helping them to decide we want to go with HPV screening and not with the existing pap smear type approaches, right? So that's where the cost effectiveness analysis comes in. It's at this high level policy choice of which test, right? But then now we're working with the people who are doing the more detailed implementation, like the actual operational implementation of how do I make this work? Who does what screening? Where do patients go next? Which patients go to which health center? And there, sorry about my kids here. They're not as concerned about the sort of overarching expected costs for many years into the future. They're more concerned is what is my budget next year and can I support this? So there's where the difference between these kinds of like fixed costs that are an upfront investment versus lab tech time every year, that makes a really big difference to them, whereas it's treated kind of as one type of thing in the high level. I think, I was saying I'm sort of new to this area of cost effectiveness analysis, but what they're really more concerned about is that year-to-year operational cost. And that we can represent very well with a discrete event simulation model based on the sort of process choices that they're making, because we can show how many hours of lab tech time are required to make a particular strategy work with certain, patient wait times and things like that.
So you're saying you convince them with the model outputs. Do you ever actually show them the model, like graphically, as I was referring to? I don't know if Harold is coming. Okay. So I don't know if Harold ever...
Sorry, I just kicked him out. He's supposed to be in a different room. Oh. Harold. All right, carry on. I've got other rooms I need to pop into. Thanks for chatting.
Sure. Okay. So I've seen these graphical discrete event simulation models where you actually watch the characters or the agents move around, like in a queuing system or whatever. And it seems like that would be quite useful. in terms of just convincing people you've got a reasonable model.
Yeah, particularly with the. Mommy tea. But you can't hold my tea, Elliot. It's full of tea. You have to be very careful. Okay. So with the decision makers in the Peruvian context, they are not. We haven't yet come up with a display that speaks to them because they were still at the level of diagramming the process in the first place. So just trying to understand what their process was is sort of more where they're at. But with the COVID lab, they've done a lot of sophisticated, like they haven't done formal analyses, but they've done a whole lot of thinking about how to improve their processing of the samples, and they've made a number of improvements. And so they are going to be much more engaged in the actual kind of viewing of the model. So you can see the samples building up at different points in time. And we visited the lab and you can basically see exactly that buildup of inventory of samples, like waiting to go through the first step, and then they build up another batch that's waiting to go through the next steps. So for them, that aspect of the discrete event simulation modeling is more valuable. Just found that with sort of, I hate to use the word unsophisticated, but folks who are just not used to visually representing what they're doing, the modeling is a step too far at first. So you start with, let's diagram something on a whiteboard, or electronic whiteboard in this day and age.
So is that project still ongoing then?
Yeah,
right.
I'm actually not a PI on that, or even formally. Patty Gravitt is the PI for that project.
Yeah.
But it's been very interesting work.
Well, I had another question. So are you considering, or will you be considering, I mean, you're going to be looking at this one particular lab. I forgot the name of it, but so what are you going to be considering other labs too? I mean, I imagine there are, like when you have COVID tests, they could go to a number of different labs, right? And so
yeah.
If one gets congested, maybe they would get sent to another lab. I mean, is that an issue?
Yeah, we've talked about that with our stakeholders. In this particular case, so first of all, we're starting with this one lab in Maryland because even understanding that in detail is large for a project of this scope. And so we decided to sort of made a conscious decision to limit the box to this lab. But Maryland has like a major testing center in the convention center in Baltimore, and most of their samples come to this lab, along with a number of samples from nursing homes and schools and universities in the area. So they have these many different sources into this one space. And then of course, yeah, there are congestion issues, but they usually go the other way. So it seems that a lot of times the private labs will get congested and they'll send overflow samples to this one. So we're seeing the opposite side of that. But it would be very interesting once we have this initial version built to look broader and say, okay, well, we have this one here and we make these process choices. What if we have another testing center over here that's maybe running a slightly different process with different throughput characteristics, and how do you allocate the samples across those different centers?
But it seems like you would have still, even though you're just modeling that one center, the presence of other centers that might be overflowing would cause spikes in inputs, right? And so you have to somehow account for that too.
Yeah, we're looking at, I mean, that's what discrete event simulation modeling is really good at, is understanding the consequences of that kind of variability in arrivals. So we're looking, some of the scenarios we'll run are what happens if you have double the number of samples you expected at the beginning of the day, or what happens if you have like a whole week or so of bigger input sizes. And then we're also interested in what about changing the policies so that perhaps you're testing certain segments of the population once a week as opposed to just when they need it, right? Which is, I think, what the policy is right now. So symptomatic people should get tested. I think that's what's happening. But what if we said everyone who works at a university needs to get tested every week, which is what my university is doing? What if we said everyone in a nursing home has to get tested every week? What capacity of that kind of subpopulation testing policy could we handle with the current lab capacity?
Right.
Or, put another way, if we wanted to scale up the lab capacity to meet some kind of target, what would that look like, or what would that require?
Right, right. So you have a tentative discrete event model set up already, and you mentioned in your proposal, you mentioned bottlenecks. Can you identify yet bottlenecks?
So the lab folks are pretty sure they know where the bottlenecks are, and we're pretty much seeing similar things, but we don't have all the data we would need to completely validate the simulation against the lab yet. But the bottlenecks, it's interesting, most of the bottlenecks are things that they've tried already to alleviate. So one was the supply of the sample tubes. So you go to the lab and they have like 10 different kinds of tubes that the samples come in rather than one. And there's one of those 10 kinds that the instrument they use can uncap automatically. They cannot buy those, right? And that could speed up their process significantly. It's
they can't buy the tubes
they can't get a hold of the tubes that this machine can uncap automatically.
Because there's a shortage, or because they're prohibited by management, or what?
No, because it's a shortage. And they just there just isn't enough supply of those. And if they had those, then the process would be significantly less manual and faster, right? They'd need more people. Right. So that's one example. The reagents that they're using are also sometimes a bottleneck. So they're buying them from different places, and that means they have to calibrate the machines more frequently. Right, there's all these kinds of small process things that add up to real challenges. And then they seem to be having a lot of struggles with, I don't know if I want to say struggles, but the folks who work for the state, I guess, have different kinds of political pressures on which kind of test or assay they're allowed to use. So they're being pushed to use one assay that maybe is slower and less good than another one for various reasons. And so this kind of like pseudo-regulatory issue has come up a number of times. And so we're trying to say, well, maybe we can help you make an argument to show like what is the real benefit to be gained by doing it the way we think you should do it, as opposed to the way that you think we should do it.
Yeah, right. Oh, okay. Is this very different from the modeling you did for Peru for the screening?
You know, in some ways it's very different, and in some ways it's not different at all. So the sort of politics around a lot of the work is not different at all. There's always someone who thinks they know the right answer, especially when you have doctors around, right? Even when the so it's been but the context is so very different, right? The instruments are very different, so the actual process that we're modeling is very different. The Peruvian process, we're using these sort of standalone, it's the same kind of instruments that you do COVID testing on, but in this case they have ones where you buy the cartridge from the company. You put the sample in the cartridge and you put it in the machine and you push go, and an hour later it reports the results back. Whereas the one they're using in the COVID lab is much more manual, but is also much higher throughput.
Right.
And the supplies for those cartridge-based ones are extremely tight right now. You just can't buy them either. They're being prioritized for like hospital settings where you need to be able to get a result back very, very quickly.
Okay. Sorry, I was distracted by. Okay, we got to 1:05. Yeah.
I don't know what's supposed to happen here.
I'm sorry?
I'm trying to figure out the same thing. So we have until 1:05, and then there's.
But then people switch sessions. So I mean, I'll stay here, but I guess you should stay here too.
I guess. So.
Yeah. That's kidding.
I wonder if there's a lot of confusion because my colleague said that she wasn't able to join.
So you have to register.
She did.
You did register.
Apparently.
Interesting. Well, I was able to get in.
Yeah, I don't know. Maybe she didn't do it properly. Thank you, Elliot. This is a stapler. Thank you. Yeah, stapler. Can you put it back for me? Yeah, can you put it back for me? Thank you. Yeah, you could put it right there.
Do you have any policy on screens for your kids, like your child?
We do. I have 2 kids. The other one is watching a screen as we speak.
Oh.
So my kids are, in theory, both supposed to be in school and daycare at the moment, but they were not able to go this week, or this yesterday and today. But yeah, we do have a screen time policy. After dinner, they're allowed to watch screens. And then in work emergency situations like this one, they're allowed to watch screens. So my older one is 5, and he can be distracted by a screen. And my younger one is 2 and is not remotely interested. So, which is perhaps not that surprising. But.
Yeah, I mean, I have friends, or maybe just one friend primarily, who's really concerned about her grandchildren's access to screens, because she cites studies that show that there's developmental issues. I looked at some of the studies, and really, in terms of the quality of the studies, the quality is pretty low, because it's just a hard question, I think, to really get a definitive answer about. But she's very concerned about her grandchildren developmentally when they're exposed to too many screens, too much screen activity, including television.
Including TV, but also like education right now is all screen based. Just a moment.
Right. Oh yeah, that's right. Well, we're talking really preschool here for her grandchildren.
Yeah, it's it's hard. It was okay before this sort of shutdown, because most people were able to send their kids to a care center, and then do screens all day. So at worst, they were watching in the evenings, and that's
right. Yeah.
That is. And that's, that was our policy, is like after dinner, screen time is okay, because that's only, I don't know, it's a half an hour or an hour max. And then every time before that, they couldn't use it. But since we've been shut down in March with 2 parents with like demanding full-time jobs, we had to use a lot more screens than we ever did before, even though, so now it's like 2 hours in the afternoon and after dinner, and maybe some times whenever it's necessary. So
Right.
It's gonna be, go ahead.
I was going to say, some of her grandchildren are growing up without any TV at all. I mean, they're, I think the oldest is 4. There's a 2-year-old, but they don't even get access to television at all. And she tells stories. I don't know. This may be selective bias, but she says, someone will come in and interact with the kids, and
I lost the battle with the piano.